Sir, Dr. Owen Swang ma'am, for allowing in touch, for participating in the MHG webinar, for allowing us. So today we have molecularly defined treatment of AML. I would like to introduce our head, Dr. Amit Khurana, sir. Dr. Amit, sir, as we all know, is a fellowship in bone marrow transplant. Sir is also practicing as a hematologist, fellowship in clinical hematology, and hematolo-oncologist practicing at Surat. Dr. Amit sir is highly skilled and experienced hematolo-oncologist with more than a decade of experience in the field. Sir has a fellowship in bone marrow transplant in hematology, clinical hematology, and is an expert in managing hematological and hemato-oncological patients. Sir has experience in performing bone marrow aspiration, bone marrow biopsy, and other hematological complicated procedures. Sir has extensive experience in both autologous as well as allogenic stem cell transplant. In order to keep the ball rolling, I would like to invite Dr. Amit sir to introduce ma'am. Dr. Amit sir, please, sir.
Thank you, Mr. Somnath. Let me share the screen. Well, very good evening to all of you, and good morning and good afternoon to all others who are joining from the rest part of the world. Today, our guest speaker for the day is Dr. Eunice Wang from Buffalo, New York, USA, and she's going to lecture us on molecularly defined treatment of acute myeloid leukemia. This webinar, as usual, is brought to you by Mumbai Hematology Group, supported by INTAS, and very well managed by Perfect Square. I thank Mr. Arun Hegde, Dr. Manoj Kumar and team from INTAS, Mr. Yash, Mr. Kalpesh and the team from Perfect Square, Executive Committee of Mumbai Hematology Group. Our guest speaker for the day, Dr. Eunice Wang from Buffalo, New York, USA. All our discussants who are themselves very eminent hematologists as well as medical oncologists, and you participants for spending your Saturday evening, morning, or afternoon from whichever part of the world you're logged in. Let me introduce our discussants for the day, and they are displayed here in alphabetical order. These are all from all over India, hematologist, hemato-oncologist, as well as renowned medical oncologist. So these are our discussions for the day. And now it's a time to introduce our guest speaker for the day. We have with us Dr. Eunice S. Wang from Buffalo, New York, USA. Let me introduce Dr. Eunice to all of you. She's the chief of the leukemia as well as benign hematology service and professor of oncology in the Department of Medicine at Roswell Park Comprehensive Cancer Center, Buffalo, New York, USA. She's also medical director of chemotherapy as well as infusion services. In addition, she has an appointment as an associate professor, Department of Medicine at Jacobs School of Medicine and Biomedical Sciences at the University of Buffalo, which is the State University of New York. She earned her medical degree from Keck School of Medicine, University of Southern California, and completed residency training in internal medicine at Yale New Haven Hospital, Yale University, New Haven City. She completed a clinical hematolo-oncology and research fellowship at Memorial Sloan Kettering Cancer Center, New York. Her research focuses on identification and translation of promising targeted and immunotherapeutic agents into clinical trials for patients with acute leukemias, particularly AML and ALL, as well as myeloid malignancies such as MDS and MPN. She has served as the principal investigator of several investigator-initiated cooperative group and industry-sponsored clinical trials for these diseases. She has authored as well as co-authored over 200 peer-reviewed articles, book chapters, and editorials. She has also previously served on the National Comprehensive Cancer Network guideline panels for AML, ALL, and MPN for several years. She is a prior recipient of a NIH Cancer Clinical Investigator Team Leadership Award, an American Cancer Society Mentored Research Scholar Award, and ESCO Young Investigator Award. In addition to her research, she maintains an active clinical practice caring for adults with acute leukemias, myeloid malignancies, and bone marrow failure states. Today she is with us and she is going to lecture us on molecularly defined treatment of acute myeloid leukemia. Well, thank you so much. I stop over here. Over to you, ma'am.
Thank you so much. I'm just going to share my slides here. Can you see these? Yes.
Yes, ma'am. Perfect. Please go ahead.
Great. So today I've been honored to speak to the Mumbai Society of Hematology on the topic of molecular divine treatment of acute myeloid leukemia. Now, as we all know, acute myeloid leukemia is a disease, at least in the United States, which is largely affecting older adults with a median age of 70 years, but it does span the entire spectrum of age groups from children all the way to the extremely elderly. In my practice, the majority of my patients and are now between 70, 75, and early 80s, just because of the number of secondary acute myeloid leukemias that we're seeing in our practice. This can be a very clinically aggressive disease, which if left untreated leads to approximately an early death rate of 30 to 50% within the first 30 or 60 days of diagnosis. This also tends to be a very clinically aggressive as well as biologically heterogeneous disease. As you can see here, this is a snapshot of what the epidemiology and the biological diversity of acute myeloid leukemia looks like at the time of diagnosis. And you can see that in addition to 50% or more of patients having an abnormal karyotype, we can see that the molecular heterogeneity of the disease is incredibly diverse, that not only are there genes that are mutated in the disease, but that these genes are incredibly different. So as they said, when you performed whole genome sequencing on one patient with AML, you have performed whole genome sequencing in one patient. And it does not a guarantee that the next patient or the next patient or the next patient is going to have anywhere near the biological characteristics of the patients that you saw previously. You can see here that not only are genes mutated, particularly in the 50% of patients that have normal cytogenetics, but there may be more than one signaling pathway that is affected. And so we see that, number one, no one mutation is mutated in more than 20 or 30% of patients. There are multiple genes, NMP1, DMNT3A, that are mutated, FLT3 that are mutated in 20 to 30%. And these mutations are often carried with other co-mutations, and it's not just the single mutation, but the presence of the co-mutations that can affect therapeutic options as well as prognosis. So in the current era at our institute, we have this diagnostic workup of patients that we suspect to have acute myeloid leukemia. For patients who present with severe hyperleukocytosis or pancytopenia, which is relatively acute, we typically suspect patients to have acute leukemias. We would perform morphology on the bone marrow and peripheral blood to determine whether this is a myeloid malignancy and whether this is acute or chronic. And we perform flow cytometry for multilineage to determine whether this represents a lymphoid or myeloid malignancy. Usually within 3 to 5 days, we also are able to get conventional cytogenetics. Within 24 to 48 hours, we are able to get fluorescent in situ hybridization as well as immunohistochemistry, again, to rule out entities such as acute promyelocytic leukemia, acute lymphocytic leukemia. Having established that this is an aggressive myeloid malignancy, we also perform on all of our patients detailed mutational analysis. We currently have an institute-wide next-gen sequencing panel, which looks at 75 different gene mutations, which are altered in hematologic malignancies, as well as oncology in general. You can see per the US NCCN treatment panel recommendations, it is suggested that an array of tests, these mutations be run within the first 3 to 5 days of diagnosis to best guide the treatment for these patients, both from a therapeutic as well as a diagnostic and prognostic perspective. So what I'd like to focus on today is how we are using some of these results to guide therapy. But I only have an hour, so I focus largely on some of the current data with targeted therapies, but I'm happy to come back at some later point and discuss some of the prognostic significances of these. There are also a second set of gene mutations which are targeted at further refining long-term outcomes and may be of therapeutic and research interest. And so these are what we call recommended to be done in the first cycle, but carry less of the importance and significance as these. So number one, you can see that there are multiple gene mutations. In the past, we would look just at FLT3 and NMP1. We now have incorporated IDH1, IDH2, and a number of what we call secondary mutations, which guide our disease. So how do we utilize these to select and prognosticate our patients? Well, this is just a general algorithm that I use just briefly when considering therapy for my acute myeloid leukemia patients. I assess the patient, and this includes their individual characteristics, their age, their functional status, their goals of care, as well as increasingly their socioeconomic and family situation to determine what might be the best therapy that that meets the patient's goals, that's appropriate for them medically, and it's appropriate for them from a personal and familiar perspective. We also look closely, and we're going to focus here on the disease process of cytogenetics, mutations, and antigens that are detected through our initial diagnostic workup to again tailor the treatment for this patient. And how do we tailor the therapy? Well, I generally think about selecting a chemotherapy backbone. Is this somebody that would tolerate a intensive cytarabine anthracycline based background, or do I consider a more intermediate or low dose regimen, or even no chemo regimen at all? And how do I incorporate targeted therapies? And here we'll talk about some of the molecularly targeted therapies. Then we consider for our younger, fitter patients, whether they are eligible for allogeneic stem cell transplantation, because I would argue that anybody with what we call intermediate or poor risk disease who is fit for an allogeneic stem cell transplantation and has the resources and the support system to do this should be considered. Patients who at onset are not eligible for allogeneic stem cell transplantation and are potentially not going to be cured or are going to be cured with chemotherapy, we would then consider the options of maintenance therapy. So we know what are some of the impacts of molecular targeted therapies. So I won't talk a lot about prognosis, but just to say that there currently are 2 prognostic systems that are being utilized in my practice for looking at how my acute myeloid leukemia patients will fare in the long term. You can see here that among these patients, we in younger, fitter patients, which are eligible for chemotherapy, that we are using the 2022 European Leukemia Net Risk Classification System, which is also advocated by the NCCN. And you can see this involves an integration not only of cytogenetics, such as translocation to E21 and version 16, and KMT2A rearrangements, but also incorporates integrated in this the mutational analysis. There recently have been 2 changes to the 2022 ALN risk classification as compared to prior, and that I just highlight here that patients with NMP1 mutant disease, with or without NMP1 mutant disease, but have presence of FLT3, are now considered to be in the intermediate category. And I think that's because of the success of FLT3 inhibitors being incorporated into therapy for these individuals. And also want to highlight now the incorporation of these mutations, AXL1, BCOR, EZH2, RUNX1, SF3B1, SRSF2, STAG2, U2AF, and ZRSR2 as secondary mutations. So in the past, we would rely upon cytogenetics or morphology or clinical history to determine whether our patients had what we called a secondary mutation or a mutation arising out of a prior hematologic disorder. And now we are increasingly relying not just on karyotype and morphology but and clinical history, but also on the clear black and white presence of these mutations. And that's why these mutations have now made it into our upfront pan-heme panel over the last year or 2. We also have data suggesting that the mutations, not cytogenetics and not necessarily clinical features like white count or prior history, but really mutations are influencing the prognosis of our patients that are getting lower intensity therapy. So you can see here in this ELN low intensity risk classification, which was published last year, that the presence of a TP53 mutation as well as other mutations in FLT3, K, or NRAS can influence the outcome not of younger, fitter patients receiving 7+3, but on older patients receiving low-intensity therapy, in this case from venetoclax and azacitidine. So you can see these mutations, TP53 is poor prognosis for older patients getting ven-aza. FLT3 ITD, or the presence of a K or NRAS mutation, is considered intermediate risk, and patients who lack any of these mutations are actually considered favorable risk, and this can influence a median overall survival, as you can see here, of approximately 5 to 6 months versus a median overall survival in the favorable group of over 20 months. So again, the influence of these mutations cannot be underestimated in terms of our treatment modalities. Now, when we look at in the US, some novel therapies that have been approved for commercial use in our patients, you can see here that many agents have been approved since 2017 till 2025, which is where we are now. And you can see highlighted here, the ones in red are the ones that are based on the presence of a specific biological subset defined by cytogenetics or increasingly on molecular abnormalities. So you can see here enasidenib, ivosidenib, olutasidenib are our IDH1, IDH2 inhibitors, quizartinib, midostaurin, gilteritinib are our FLT3 inhibitors, and the approval last year of revumenib is now opening the door for targeted therapy for NPM1 mutant as well as KM2 rearranged disease. So now turning to the therapeutic implications of these, I'd like to talk a little bit about each of these targets, molecular targets that we now have in acute myeloid leukemia, and demonstrate the increasing amount of data and how we are treating patients based on these molecular aberrations. So FLT3 was the initial game changer, as we say, for the development of targeted or molecularly directed therapy for acute myeloid leukemia. And so targeting FLT3 in 2017 with midostaurin opened the door for us to now have the precision medicine approaches that we currently utilize. As you know, FLT3 mutations occur in 25 to 30% of patients, 37% in some studies that are newly diagnosed with acute myeloid leukemia. In many cases, the majority of these mutations are mutations in the internal tandem duplication region here, but we also have, and that leads to a elongation of this intracytoplasmic domain of the FLT3 tyrosine kinase inhibitor that is found on normal hematopoietic stem cells and on myeloid blasts. Mutations in this FLT3 receptor lead to constitutive activation and expression of the receptor that promotes proliferation, pro-survival, and therapy-resistant mechanisms in cells that bear this mutant FLT3 receptor. The second mutation is one mutation in the tyrosine kinase domain here. Both of these lead to activation of this receptor and further growth of cells and are associated with transformation of myeloid blasts. We can see that ITD, the presence of a FLT3 ITD, was associated with worse survival to conventional cytarabine and anthracycline-based chemotherapy in the past, whereas the TKD mutation was not as significantly implicated in prognosis. But the presence of these led to the development of multiple FLT3 inhibitors blocking this aberrant FLT3 kinase mutant receptor. So you can see that there are two types of FLT3 inhibitors, type 1 inhibitors and type 2 inhibitors. Type 1 inhibitors bind both the active conformation of the FLT3 tyrosine kinase receptor that promotes activation and proliferation, and these inhibitors include midostaurin and gilteritinib. In contrast, there are type 2 inhibitors that only bind the FLT3 receptor in its inactive conformation, and therefore are only able to hit the ITD, but are not able to target the TKD mutation, which is not exposed in an inactive conformation. These types of inhibitors importantly include sorafenib as well as quizartinib. So currently there are what we call first generation, second generation inhibitors. The second generations here are in red. And as over time, midostaurin was initially investigated as well as sorafenib because they were tyrosine kinase inhibitors which were repurposed from other cancer therapy regimens into the treatment of acute myeloid leukemia. and were found incidentally to inhibit the FLT3 kinase mutant receptors, you can see a very high IC50. The subsequent newer generations, quizartinib and gilteritinib, as well as this one crenolinib, were second generations, which, as you can see here, have several-fold more potency as well as specificity only for the mutant FLT3 inhibitor and other very limited tyrosine kinases, and have a higher potency. And you can see here some of the results being translated into clinical practice. As we know, in 2017, with the publication of the RATIFY trial, we saw for the first time that adding this particular first generation FLT3 inhibitor, midostaurin, which targets both TKD and ITD, to standard 7+3 led to about a 7% improvement in overall survival. You can see here that the FLT3 inhibitor was incorporated in upfront induction as well as consolidation and maintenance therapy, and there was a statistically significant improvement in overall survival, about 7%, although the total complete remission rate remained very similar in these patients. We also know from further post-hoc analysis that the benefit of midostaurin added to 7+3 was not just the survival benefit but was also linked very closely to receiving the FLT3 inhibitor and then proceeding on to a stem cell transplant in first complete remission. And you can see here that patients getting an allogeneic stem cell transplantation, both receiving placebo or midostaurin, had higher survival. And in the absence of a stem cell transplantation, the benefit of midostaurin was negligible. We now have quizartinib. Quizartinib is a second generation inhibitor that inhibits only FLT3 ITD, so it's a type 2 receptor tyrosine kinase. In the prior study, we had looked at younger patients, ages 18 to 59. In this study, the quizartinib, the quantum first study, the age range was broadened to 75, and treatment with the quizartinib was extended for up to 3 years. And you can see here again, similar design, 7+3 plus quizartinib, consolidation with high-dose cytarabine, followed by quizartinib maintenance. And you see again an improvement in the median overall survival of these patients being treated with quizartinib versus placebo as part of intensive chemotherapy. Looking now at newer technology, we are able to examine the presence of the FLT3 ITD mutation in these patients via highly sensitive next-gen sequencing and molecular minimal residual or measurable residual disease. And you can see that after induction, after consolidation, and after the last consolidation, you can see here, this was the measurement of the FLT3 ITD minimum measurable MRD status. And you can see at each time point after induction, after consolidation, and after the last consolidation, that much less detectable ITD, and the MRD positive patients were much higher in the patients that were getting chemotherapy in the absence of FLT3 mutations, suggesting that the specific addition of FLT3 inhibition can render more patients MRD negative and improve outcomes for that reason. Now, the question has been, at least in our country, which inhibitor to use. Should we use midostaurin? It's a little bit broader, targeting ITD and TKD. Should you use quizartinib, which is associated with cardiac toxicity, specifically QTc prolongations? Which one is the better inhibitor for our patients? And so as you compare the results from in both of these trials in the same patient population, 18 to 59, you can see that these results look actually very similar when putting them back to back. Now, this is not a fair comparison. We don't have data comparing midostaurin directly with quizartinib. Both of these studies use placebo as the control group, but you can see here that although we've improved the outcomes, these curves are, if anything, very comparable when we look at them over time. What about older patients, patients unfit for intensive chemotherapy? In these patients, we haven't used lower intensity therapy, as you can see here, then and hypomethylation agents, and we've added a FLT3 inhibitor on top. We're calling this sort of like triplet therapy as opposed to low-dose chemotherapy and FLT3 inhibitor. And you can see that the addition of a FLT3 inhibitor to the backbone ven-aza that we're using in our older and unfit patients actually leads to very, very high CR rates. And you can see here, CR rate of about 93% in these patients as opposed to 59% or 60% with intensive chemotherapy. In our younger patients. And you can see that again, high numbers of MRD negativity, both molecular and by flow cytometry. Looking at a specific regimen, this is the combination of the gilteritinib, again, a second generation type inhibitor blocking both FLT3 and ITD and TKD, in combination with Ven/Aza in newly diagnosed older unfit patients with FLT3 mutant disease. And you can see here that the CR rate is 90%, about 100% had some evidence of clinical benefit from the combination of a FLT3 inhibitor and Ven/Aza, and about 56% of these patients had, after cycle 1, MRD negativity. By 4 cycles of therapy, 93% of these patients were actually MRD negative. And actually, for these patients that were healthy enough, almost half of them actually, with this particular MRD negative strategy, were able to undergo allogeneic stem cell transplantation in first remission with hardly any mortality. Overall, even patients who were not able to go to allogeneic stem cell transplantation, many of them, 3/4, were alive about 18 months after upfront therapy. So the question is, since we're doing so well with this therapy, how does this compare to FLT3 7+3 in younger patients? And you can see here just a comparator data, the quizartinib 7+3 outcomes and the gilt Ven/Aza outcomes, and you can see for yourself which one looks a little bit better. So there is currently planned a randomized nationwide study which will be looking at comparing quizartinib 7+3 to a quizartinib Ven/Aza backbone to determine whether this lower intensity therapy should be utilized for everybody. Because one can say, as we see in other diseases, including acute lymphocytic leukemia, when you incorporate a potent targeted agent in addition to chemotherapy, even for this highly aggressive acute malignancy, the benefit of adding a targeted therapy is that you might be able to reduce the backbone therapy and then make the treatment option safer and well tolerated for all individuals, not just older patients. So we will need to wait for the results of that study. We know that in patients who have relapsed and refractory FLT3 mutant disease, that FLT3 inhibition is definitely better. In this study, the AML trial done several years ago, patients who had relapsed and refractory FLT3 mutant disease were randomized to receive a FLT3 inhibitor alone, and they could get followed by a stem cell transplant if possible, or salvage chemotherapy. And the salvage chemotherapy included high intensity therapy with mitoxantrone, toposuberxateramine, and fludarabine, intermediate dose cytarabine, idarubicin, and G-CSF. So nobody would anticipate that this one pill daily would perform better than high intensity salvage chemotherapy administered in the inpatient setting for 4 to 6 weeks. And what we found, however, was that regardless of whether it was high or low intensity therapy, that gilteritinib had, I would say, almost double the median overall survival as compared to chemotherapy lacking any FLT3 inhibition over time. More patients achieving a response, 37%, with gilteritinib, almost double what we saw with salvage chemotherapy. And this was the first sign that really targeted therapies could be even superior to intensive backbone therapy for our patients. You can see long-term follow-up of patients in this initial ADMIRAL study showed that that any of these patients who were pre-selected either for low-intensity therapy, who went on to allogeneic stem cell transplantation. It's a very, very small number, but you can see that there are a number of patients getting subsequent to allogeneic stem cell transplantation that were still alive. And we have a young patient in our practice who's still practically cured of her disease several years after this type of approach, as opposed to those getting standard of care. So allogeneic stem cell transplantation still remains for both intensive and less intensive regimens, something that needs to be incorporated into therapy. But similarly for our fit patients, our relapse patients also, the only long-term survival is the incorporation of a FLT3 inhibitor, as well as followed by allogeneic stem cell transplantation. Can we improve our outcomes of allogeneic stem cell transplantation when we know that from this study, the SORMAIN study several years ago, where they randomized patients with FLT3 mutant disease into receiving either sorafenib or placebo in the post-transplant setting as maintenance. You can see here that both in terms of relapse-free survival and overall survival, patients receiving FLT3 inhibition with sorafenib in the post-transplant setting did significantly better than those that got no FLT3 inhibitor therapy post-transplant. That has led to the recently published Morpho study, where again, they took patients with FLT3 mutant disease and FLT3 ITD disease. They registered them onto this trial, and they underwent an allogeneic stem cell transplantation within 1 year of attaining complete remission. They had samples done prior to and following transplant for measurement of this FLT3 MRD by our molecular assay, and then they were randomized to receive either FLT3 inhibition with gilteritinib or placebo for 2 months. Now, the results of the study overall was to look at primary objective was to look at relapse-free survival versus overall survival. And you can see that there was no difference in overall survival, that there was a difference potentially in relapse-free survival that favored the gilteritinib, but the p-value, which you can't see here, right here, was not statistically significant. You can see it was 0.05, so barely missed clinical significance. As we talked about, we had patients measured for minimal residual disease prior to and following transplant. So you can see that about 46% of patients had MRD positivity by either 10 to the -4 or 10 to the -6 molecular assay prior to transplant. And then you can see here that 46% were MRD positive before transplant, 4.5%, 20% were detectable post-transplant, and this included 4 to 5% of patients who were undetectable prior. So approximately half of patients were MRD positive or negative prior to or following transplant. And you can see in patients that were MRD positive, there was a huge difference. You can see here a p-value of 0.006 in terms of benefit to receiving the FLT3 inhibitor after transplant, where in patients who are MRD negative, there was no benefit, which makes sense because it suggests that if you are able to eradicate the FLT3 mutant disease by chemotherapy and allogeneic stem cell transplantation, that there's no benefit to receiving that FLT3 inhibitor post-transplant. Whereas if you still have residual disease that has not been eliminated by chemotherapy and transplant alone, it is very important to have a gilteritinib on board. Now, that doesn't mean that you don't still relapse. You can see that there's still about a 25% relapse rate in these patients, but definitely it's improved as opposed to the 50%, almost 50% relapse rate in patients MRD positive who did not get the gilteritinib. Now, moving on. What about these other molecularly targeted therapies? FLT3 is only detected about 25–30% of patients. Well, we can look at IDH1 and IDH2 mutations. These mutations are less common. You can see that IDH1 mutations occur in about 6 to 10% of AML. IDH2 mutations occur in 9 to 13% of mutations. We know through elegant preclinical and basic laboratory research how these mutations function. Both IDH1 and IDH2 are involved in critical metabolism pathways that promote tumor growth. Both of these mutations, either in IDH2 or IDH1, lead to upregulation of this metabolite, alpha-ketoglutarate. This alpha-ketoglutarate is converted into 2-HG, which is a malignant oncoprotein. And the presence of 2-HG in the cytoplasm of these hematopoietic cells leads to alterations in chromatin regulation, and which then lead to impaired cellular differentiation, and the cells get stuck again in that myeloblast stage and then are promoted to proliferate. And so this particular mechanism leads directly to leukemiogenesis in patients that have these mutations in their leukemia cells. There currently in the US are 3 inhibitors that are available for treatment of IDH1 and IDH2. There's ivosidenib, which is a first-generation IDH1 inhibitor, olutasidenib, a second-generation inhibitor, and one IDH2 inhibitor, enasidenib. And you can see here that in our young and our older unfit patients, when you look at treating these patients, the addition of this IDH1 inhibitor to azacitidine can lead, and older unfit patients can lead to pronounced overall survival benefit. You can see here, Ivo-Aza together leads to a median overall survival at 24 months as compared to 8 months in patients getting azacitidine alone. Of note, this ivosidenib plus azacitidine is extremely well tolerated. There is a small incidence of differentiation syndrome as well as a small incidence of QTc prolongation, which you need to watch out for. But you can see that any grade anemia, febrile neutropenia, thrombocytopenia infections was only about 28%, and the grade 3 infections with the combination of ISO was only about 21%, and the anemia, cytopenia is only happening in a quarter of patients, which and the infectious complications with Ivo-Aza were actually less in this study numerically than patients getting azacitidine alone. And so when we look at our standard therapy, which is venetoclax azacitidine for these older unfit patients, and we look at the Ivo-azacitidine for these patients, when you look at the VIALE-A trial as opposed to this trial, you'll actually see that the CR rates are maybe comparable, 53 to 67%, but the median overall survival of Ivo-Aza is at least as good as that with Ven-Aza. And as you know, with venetoclax azacitidine tends to be a very cytopenic regimen, with 7% of patients dying within 30 days of largely infectious related complications. The differences between these regimens are striking. There is an incidence of QTc prolongation and differentiation syndrome with an Ivo-based regimen. However, I would argue that in contrast to Ven-Aza, it's much better tolerated, and the Ivo-Aza regimen we actually give in the outpatient setting. However, this does require that at the time of diagnosis, that patients have detection of that IDH mutation, and so I think that for many areas of the world where you can't get the IDH mutation back, it may be feasible to start with Ven-Aza, then getting the mutation back if we have availability to potentially switch. But this has been the major, just the lack of detection has been, I think, a barrier in us using this particular very effective regimen in the upfront setting. What about triplet therapy? What about combining an IDH inhibitor plus Ven-Aza, just like we combined gilteritinib or FLT3 inhibitors plus Ven-Aza? So this is some data recently published by the MD Anderson group looking at triplet regimens where they used either ivosidenib or enasidenib plus venetoclax and hypomethylating agents in 60 patients with newly diagnosed intensive chemotherapy and eligible disease. You can see that the 60-day mortality out of these 60 patients was 1 patient. And the follow-up was almost over 2 years. About a third of patients went to allogeneic stem cell transplantation, but you can see with this triplet regimen that the overall response rate was about 92%, as you can see in IDH1, IDH2, MRD negativity 81%, in IDH mutant disease 100% overall response rate with 95% 30 to 60 mortality thing, and you can see that when we look at 2-year overall survival, about 2/3 to 3/4 of patients are alive at after 2 years of therapy. You can see here we see the overall survival, 2-year overall survival 65 to 73%, event-free survival 60 to 72%. So these are clearly very impressive curves that we're now able to have these AML patients, the majority of them alive 2 years or longer with the combination approach with the FLT3 inhibitor. And you can see again, is this combination IDH inhibitor and Ven-Aza, how does it compare to intensive chemotherapy? So these are the results of an intensive chemotherapy regimen utilized at MD Anderson for a similar IDH population. You can see here that these patients do very, very well, potentially even a little bit better when you look at the adverse risk category. And obviously, when you look at the intensive chemotherapy for these patients, those instances of febrile neutropenia in the majority of patients, bacteremia, lung infection, again, as compared to much lower rates, about half those rates in this triplet combination. So again, we can use IDH1, IDH2 inhibitors in the relapse setting, but you can see that even though they do get some responses, the overall benefit of these, I think, would be best seen in using these inhibitors in the upfront setting. We do have a new inhibitor, olutasidenib, which I won't discuss here, that also can have a median duration of response in the relapse refractory setting of up to 29 months. So these, the combination of the upfront approach as well as subsequent salvage approaches is looking very promising, and there are studies looking at whether olutasidenib will function better than ivosidenib in the upfront setting. So last, I'd like to end in the last maybe 15 minutes of my talk talking about a new molecularly targeted approach for acute myeloid leukemia, and that is menin inhibitors. And menin inhibitors are a novel class of agents which was pioneered to look at two other molecular subgroups of acute myeloid leukemia that previously had no specific targeted therapies. And those are patients with NPM1 mutant disease, as well as patients with KM2 rearranged disease. NPM1 mutant disease occurs in up to a third of newly diagnosed patients who have acute myeloid leukemia, primarily patients that have normal karyotype. This often co-mutated with other genes such as IDH1, IDH2, FLT3, and DMNT3A. And in the absence of a FLT3 mutation, we feel that patients with NPM1 mutant disease with wild type FLT3 can do very well with both intensive chemotherapy as well as less intensive chemotherapy approaches in the absence of any targeted therapy. KMT2A rearranged disease, however, is a different subset. This is more rare, occurring in about 5 to 10% of patients. These are KM2 rearrangements or fusion of the 11q23 MLL gene with a partner fusion gene occurs largely enriched in infant ALLs, infant and pediatric ALLs, as well as younger patients. We also find an increased incidence of this KMT rearrangements in patients who have prior anthracycline exposure. So patients, for example, breast cancer patients who are receiving anthracyclines as part of their upfront breast cancer therapy often can recur as early as 1 or 2 years after completion of breast cancer therapy with KM2 rearranged diseases. We have also seen KMT2 rearranged diseases in patients with other solid tumors such as GYN tumors. The presence of a KMT2A rearrangement is considered both intermediate to adverse risk in the European Leukemia Net risk classification, and these patients typically do poorly with intensive chemotherapy and are only cured in the setting of a subsequent allogeneic stem cell transplantation. So how do these menin inhibitors work? You can see that in KMT rearranged disease, we have our MLL gene, which is fused with a partner gene. There's about 80 different partner genes it fuses. This aberrant protein creates a KMT rearranged epigenetic complex, which interacts with the chromatin on the DNA and upregulates a gene expression profile, which incorporates 2 transcription factors as well as others, HOXA9 and MEIS1. Upregulation of these factors leads to a gene profile or a subsequent activation of pathways that lead to leukemiogenesis, in part by leading to differentiation block. This entire KM2 rearranged master transcription complex has been previously documented as being sort of the key for why KMT rearrangements, regardless of their fusion partner, are driven to promote tumorigenesis. Now, of note, this KMT2A rearranged complex relies for activation and sustenance on a protein-protein binding with this protein menin. Menin is a nuclear scaffold protein, which was initially identified in patients who've had multiple endocrine neoplasia. So we know that menin has had a role in tumor development in solid tumors for quite some time. But the unique entity here is that menin, binding of the menin protein to this KMT2A complex is needed for this whole leukemiogenesis pathway. So we, for many years, have tried to target this particular complex with various therapeutic approaches without success. But it was found several years ago that instead of targeting this directly, we could target the menin. So we have an inhibitor here that actually is a protein-protein inhibitor, blocks the binding of the menin protein to the KMT2A transcriptional context. That alters this complex. It is no longer able to bind to the DNA, and therefore it leads the inhibition of the menin results in transcriptional changes in the cancer cells. And you see that there is decreased HOXA9 in MEIS1, and actually what that leads to is the myeloblasts in acute myeloid leukemia to actually differentiate terminally and leads to cell death and apoptosis. How does this work in NPM1 mutant disease? Well, it turns out that the NPM1 mutant protein interacts with this KMT2A complex to drive leukemiogenesis in these particular patients. And so when you look at the gene expression profile of patients with NPM1 mutant disease, they have the same upregulation of HOXA9 and MEIS1, some of the same biological processes which are altered similarly to what we see in KMT2A. So similarly, and that is because the NPM1 protein, which is mutant in this case, interacts with this complex to cause the disease. So similarly, if one blocks the interaction between menin and KMT2A in these NPM1 mutant patients, you will lead to similar differentiation effects, cell death, and apoptosis. And so there are multiple drugs now which have been identified which block the protein-protein binding of menin to this KMT2A complex. You can see here some of the names: ziftomenib, enzomenib, bleximenib, and revumenib, and you can see that all of these drugs are potent inhibitors of the protein-protein binding of menin to this complex at about 0.5 to 9 nanomolar. So there's not clearly out of these agents one that's significantly more potent, but they all have similar binding profile. So right now is what is the best menin inhibitor, because there you can see all of these menin inhibitors are all being in development. We know revumenib was the first to be approved, but we can see here that the other menin inhibitors, at least in our studies, are rapidly coming to the forefront. And there are differences between these menin inhibitors that are just being developed. Is there a difference between patients who have KMT rearranged disease versus patients that have NPM1 mutant disease? What about prior therapies? Do they influence the sensitivity of relapse patients to these inhibitors? What are the toxicities? Some of these toxicities are toxicities we see across the class, whereas some of them, like the QTc prolongation, are specific to one agent. What about resistance? And of course, because they work in the relapse refractory setting, what about bringing them to the forefront for combination studies, both in the relapse and the upfront setting? So revumenib is the first menin inhibitor which has been approved in the United States for treatment of patients with both KMT rearrangements and NPM1 mutant disease. This was a phase 2 study looking at the efficacy of revumenib at these doses. As you can see here, a couple of things to keep in mind with the use of this agent. Number one, it does interact with CYP3A4 inhibitors, so we have to dose reduce it about 50% in the presence of azoles. There also is a significant interaction with this drug causing QTc prolongation. We'll be discussing that similarly. The primary endpoints of this phase 2 study really was response rate, safety, tolerability, and other entities. And you can see here that overall in the KMT rearranged patient population, the overall, even though there was some activity in up to 2/3 of patients, the true CR/CRh rate was 23%. And about 61% of these patients were MRD negative. And the true CR rate you can see here with the median follow-up, short follow-up was only about 15 or 16%. The median duration of this response for those patients achieving a response was about 6.4 months, with the overall survival about 8 months. What are some of the side effects? Well, you can see that there was this QTc prolongation. So in patients who had QTc prolongation, about 29% of patients had, so about a third of patients had QTc prolongation, and in 44% of these patients, it was grade 3 and above. And in 41% of these patients, 50% of patients did require dose interruptions or dose reductions due to this QTC prolongation, which occurs usually within a week or two of starting drug. You also see that patients can develop a differentiation syndrome, and that's because of the biology of how these drugs interrupt and affect leukemia cells biologically. And you can see again, the incidence of differentiation syndrome was about a quarter of patients, and this can be severe, grade 3 and grade 4 events, with dose interruptions occurring in about 29% of patients, and again, occurring very early on within the first week or two of initiation of therapy. What about patients with relapsing refractory NPM1 mutant disease? So you can see here the other arm of the study that there were about 64 patients treated who had relapsing refractory NPM1. The CR/CRh rate is almost exactly the same, about 23%. You can see that patients who had prior venetoclax and prior FLT3 inhibitor, they're actually the CR/CRh rate is even lower, 13 to 16%. And the duration of the response was also lower, only about 4.7%, with an overall survival of only 4 months. There also was QTC prolongation in about 43% of patients, with about 23% having grade 3 and above. And about a 19% incidence of differentiation syndrome, again, 13% being grade 3 and above. The second menin inhibitor, ziftomenib, is up for FDA approval, and so this is not yet approved yet, but data up till now, ziftomenib has primarily been studied in patients with this relapsing refractory NPM1 mutant disease. And again, in this phase 2 study at a dose of 600 milligrams, you can see that the CR/CRh rate was very similar to revumenib, about 23 to 25%, about 2/3 of patients being MRD negative. In contrast to ziftomenib, there seemed to be activity which was retained in the presence of prior venetoclax. So there was transfusion independence, there was activity regardless of prior therapy, and you can see responders in this NPM1 mutant cohort had a median overall survival of about 16 months, as opposed to non-responders, which was 3.5 months. And the median overall survival was 6 months. Again, differentiation syndrome occurred in 25% of patients, 15% were grade 3, but there was no QTC prolongation. There was only 3 patients out of almost 100 patients who had QTC prolongation, so this was not detected in these patients. There is bleximenib, which is another J&J study drug, which is also a very potent menin inhibitor, also induces differentiation syndrome in about 20% of patients, but no significant QTC prolongation. And again, CR rates, we think of about 20 to 30% in patients with both KMT2A and NPM1 mutant disease. And there's a fourth inhibitor, enzomenib, that is being developed by a drug Sumitomo that is different chemically from the other drugs, and has been safely dose escalated with very low rates of differentiation syndrome, only about 11%. And you can see again, overall response rates that look to be a little bit better, maybe 30 to 40% in small numbers of patients to date. So we can see overall, when we look at these menin inhibitors, we can see CR rates about true CR rates 15 to 20%, but they're all about 20 to 30%, with maybe some of the newer inhibitors being potential to have a slightly higher. And median overall survival, however, is only a matter of months. We see across the board differentiation syndrome occurring in 20 to 25% of the early inhibitors, maybe a little bit less in the newer inhibitors, and QTC prolongation really being associated with revumenib. We do know that there are mutations in the menin protein which occur. So this data in revumenib show that up to 39% of patients can develop a mutation in the menin protein, which correlates with the development of clinical relapse. As you can see here, recurrence of peripheral blasts in these patients. These mutations were not found at screening and only found after revumenib therapy, and obviously occurring within a matter of months. We know that each of these menin inhibitors, this is the menin protein by crystallography, and these are the binding sites of each of these menin inhibitors to the menin protein. So each of these menin inhibitors binds, you can see slightly different areas of the menin protein, and some of these are overlapping and some of these are not. And so these, it is thought that different menin inhibitors are likely to generate different mutations. And we've already seen with this bleximenib drug that there are some mutations occurring in patients getting bleximenib, which are different from those getting the other inhibitors. So we've now, so how do we overcome this? Well, there are now some early studies looking at, this is a study of the menin inhibitor Zifto plus 7 and 3. And you can see here that the combination of a menin inhibitor with 7 plus 3 leads to an overall total response rate in 100% of patients, CR in 100% of NPM1 mutant patients. 83% of patients with KMT2A achieved a CR after 1 to 2 cycles of therapy. We also see that when you combine the menin inhibitor, here you can see bleximenib plus venetoclax azacitidine. In these patients, again, in the newly diagnosed setting, we're getting CR rates of over 65% patients getting CR/CRh, and overall response rates of 90%. So moving forward, we're probably going to see patients getting menin inhibitors in the upfront setting more and more and more. Here's another study where revumenib was combined with ven-aza. Again, CR rates 80%, 90%, which we think would be a little bit higher than one would anticipate with ven-aza alone. So I'd just like to end by just highlighting some of the novel targeted therapies moving forward that were being incorporated into our upfront therapy. So with the incorporation of menin inhibitors, IDH1, IDH2 inhibitors, and FLT3 inhibitors, I can now say that we have a targeted therapy available for more than 50% of patients with newly diagnosed acute leukemia. With the incorporation of these target inhibitors in more than half of our patients and the use of both low intensity and high intensity regimens, I think that we have made a lot of progress, enormous progress in the last several years. And moving forward, I think one future aim would be, as we incorporate these targeted therapies, would be to standardize some of these molecular diagnostic techniques in our newly diagnosed patients across the world, so that and then making some of these inhibitors available to patients throughout the world. And then I think in the future, hopefully with the integration of these, we can finally get away from 7+3 based therapy and really be incorporating low dose chemotherapy for all patients. So with that, I'd like to end, and I'm happy to stay on the line to discuss whatever questions people may have.
Thank you so much, ma'am. Wonderful talk, fantastic, almost complete, beautiful lecture. Learned a lot from you, ma'am. And I now request all our discussants to please put the hand raise signs so that we can start our discussion with Dr. Eunice Wang. So in the meanwhile, I have some questions from the audience.
Sure.
There's a question asked from Dr. Shyam. He has a 45 years old AML with FLT3 TKD with NPM1 mutation on AZA plus ven induction. Patient attained complete remission. What would be the preferred consolidation therapy?
So in our patients, we would consider venetoclax azacitidine in some form until the patient stops responding. So how old is the patient? 45 years old?
45.
So I would think that if the patient has achieved a complete remission with venetoclax azacitidine and the patient has NPM1 mutant and TKD mutant disease, right?
Yes.
So I think that you could continue the venetoclax azacitidine, but in a 45-year-old patient, I don't think it's feasible to continue venetoclax azacitidine for a long period of time. So what we have done in these particular patients is sometimes if you've achieved a response with ven-aza induction, you can give high-dose cytarabine consolidation in patients that have NPM1 mutant disease, because we know that patients who have that disease in the absence of a FLT3 TKD can do very well with cytarabine-based therapy. So I think one possibility would be to give consolidation chemotherapy with this patient. And I would give, the standard, for NPM1 mutant disease, we typically give 3 to 4 HiDAC consolidations. And in our country, we might, in our center, because patients respond very well, we might add GO to the consolidation regimens if you have that as an option. The goal would be to try to achieve an MRD negative response and to eradicate the disease with the high-dose cytarabine so that you would not necessarily need to go to allogeneic stem cell transplantation. I don't know of any data looking at the long-term outcomes of a ven-aza induction in these individuals followed by HiDAC. I think that's something that increasing numbers of people are doing, given the limitations and not being able to give a high-dose cytarabine 7+3 based regimen. But I think that I would, if possible, in this 45-year-old, move to a HiDAC consolidation and try to see whether that approach would control the disease. And then the question would be, would you transplant that patient? So I think in our center, if we were able to achieve MRD negativity after intensive chemotherapy, we are just thinking about whether we would still send those patients to transplant or whether we wait for first relapse. So I think it would depend on whether the patient is eligible for transplant, whether it's feasible to do a transplant, or whether you have the ability to give HiDAC consolidation, render the patient MRD negative, and monitor the patient to see whether it's possible for them to avoid transplant. So I hope that was helpful in some way.
Thank you, ma'am. Another question is from Dr. Shyam. He has a 55 years old AML with SRSF2 mutation only. What would be the preferred induction as well as consolidation?
So for a patient with SSRF2 mutations, which we would consider a secondary AML mutation, I think that it depends. If it's a younger fit patient, we may give a 7+3 based regimen. But for secondary mutations, we also have found that a ven-aza based regimen can lead to high responses and are well tolerated. Given the fact that they're 55 years old, however, with the secondary mutation, our plan would be for these individuals to receive an allogeneic stem cell transplantation. In our center, the choices would be at the time of induction with, given that secondary mutation, with a liposomal. So we have used liposomal CPX351 for secondary AMLs, or we have used ven-aza for these individuals, with the plan for, regardless of your induction chemotherapy, to move towards doing an allogeneic stem cell transplantation in CR1, given their young age and the presence of that sort of poor prognostic mutation.
Thank you, ma'am. Another question is from Dr. Krishna Ratnam Kannan. How do you monitor for MRD in FLT3 AML?
Okay, so for all patients at our center, we have for many years been using an MRD flow assay, which has a level of detection of 0.01%. However, we found that for patients that have a molecular abnormality, that we can follow that the molecular MRD also can be incredibly helpful. So we typically do flow on everybody, and there's data suggesting that both flow and molecular can be helpful in these patients, because sometimes, for example, the FLT3 ITD is a very what we call promiscuous mutation. So that mutation can come and go over the course of therapy. For patients who have FLT3 ITD mutations, we typically now are using a next-gen sequencing assay, which looks specifically at the ITD. And that has an increased sensitivity of 10 to the -6. And that is the similar assay to what was similar detection levels that have been used currently in the Quantum First trial. So I showed that data with MRD with the quizartinib decreasing MRD across the board as compared to placebo 7+3. And the Morpho trial looking at MRD prior to and following transplant also used that specific FLT3 ITD MRD assay. So we are using that, and we, in terms of whether patients get subsequent FLT3 inhibitor after allogeneic stem cell transplantation, we're using that FLT3 ITD MRD because that was the same assay used in the Morpho to determine which patients should get subsequent FLT3 inhibitor post-transplant. We typically do the post-transplant FLT3 inhibitor for 2 years.
Thank you, ma'am. And this monitoring of MRD is from peripheral blood or from bone marrow?
So we typically, the sensitivity of the assay is from the bone marrow. So what we typically do is we will follow it in the marrow, and when it turns negative in the bone marrow, then we don't want to do a bone marrow every 3 months. So then we start checking it in the peripheral blood. If the peripheral blood if there's any cytopenias, or if the peripheral blood turns positive, there's any suspicion that the peripheral blood, there's residual disease, then we would repeat the marrow. But otherwise, we try to do it from the peripheral blood after establishing whether it's positive or negative in the bone marrow, just because of a feasibility. Some of the MRD assays we do not do. Certainly the molecular MRD assays we do not do in-house. We send those out to commercial labs. So the MRD assays do take a couple weeks. We do it in the marrow first. Once it turns negative, we go to the peripheral blood. We go back to the marrow if needed.
Thank you, ma'am. Another question is from Dr. Shailesh. For NPM1 mutated patients, do you suggest Ven plus EZA over intensive induction, even in fit patients?
I think it depends a little bit on, as we talked about, the patient. So if the patient has NPM1 mutant disease with FLT3 ITD negative, and they're younger and fit, then my standard is to give 7+3 plus GO as induction, followed by HiDAC consolidation with GO for 2 cycles, and then HiDAC consolidation without GO for 2 cycles. And then if they're NPM1 mutant, MRD negative, then we would just do observation at that time. For patients who have NPM1 mutant disease, which has poor prognostic, so we know that FLT3 ITDs or TKDs, we are giving them 7+3 plus a FLT3 inhibitor, okay? Particularly for patients that have NPM1, FLT3, and DMNT3A, those patients respond very, very well to incorporation of a FLT3 inhibitor into their regimen. If they have those diseases, if they're FLT3 mutant with NPM1, then my plan would be to do an allogeneic stem cell transplantation in CR1. If they're NPM1 but they're FLT3 negative, and they have some poor prognostic features, like I have patients that have NPM1 with secondary mutations, or NPM1 with the WT1 mutation or NRAS mutation. Those patients I feel like are not going to do well if they're young and fit. So I am enrolling those patients on clinical trials with the menin inhibitor for the treatment of a sort of a adverse risk NPM1 mutant patients. And those patients I feel like probably should go to allogeneic stem cell transplantation. For older unfit patients that cannot get an intensive regimen, I really try to do an intensive regimen for all my NPM1 mutant patients, if possible, in the younger fit population. If they're older and unfit, again, I would do a Ven-Aza based regimen. Patients with NPM1 mutant disease tend to do well with the Ven-Aza based regimen, but they can't be cured with that regimen. We are looking at, if they're FLT3 NPM1 mutant, then I'm doing a FLT3 inhibitor plus Ven-Aza. If they're IDH co-mutated, I'm trying to do a clinical trial of putting an IDH inhibitor plus Ven-Aza. So I think Ven-Aza for NPM1 mutant older patients is a reasonable approach. But because you're not going to cure patients with Ven-Aza alone, even if they do well with that, I'm trying to put something else with it, whether it be a FLT3 inhibitor, an IDH inhibitor, a menin inhibitor. And again, depending on their overall risk factors, some of those patients are also going to allogeneic stem cell transplantation. in a reduced intensity setting if they achieve a good response and if their performance status allows. Sounds a complicated answer, but I think the NPM1 mutant patients are receiving a lot of attention nowadays because we have these new inhibitors and targeted therapies and lots of different options for them.
Thank you, ma'am. And for older patients who are IDH1 mutated, EZA plus Ven versus EZA plus IVO, what would be your choice?
If I know the patient has an IDH1 mutation, I'm doing IVO-AZA if I can get that because it's so well tolerated. And I can do it outpatient. There's no cytopenias. There's hardly any infections. And I have had patients on IVO-AZA continue on IVO-AZA for like 2, 3, 4 years. If they have a lot of trouble with the AZA, I've even dropped the AZA and just continued the IVO alone. I think that that's a really great regimen, particularly for older unfit patients that really are not going to go to allogeneic stem cell transplantation. Why would I do? So for IDH2 disease, the data that we don't have a corresponding trial for enasidenib, AZA versus AZA, like we have the Agile trial definitely showing that ivosidenib is better. We don't have similar data for enasidenib in that setting. And we tried to do that trial, but the trial showed a higher response rate with AZA, but not necessarily improved overall survival with that approach. So I'm not necessarily doing enasidenib AZA versus, and patients who have IDH2 mutations do very well for some reason with Ven-AZA. So for IDH2 mutated patients, I'm still sticking with Ven-AZA. There is some early data saying if you're resistant to Ven-AZA, I'm sure we all have these patients say relapse after Ven-AZA. When you relapse after Ven-AZA, your prognosis is horrible. And so there's some data that have anecdotal data at some centers, small numbers of patients at centers, including MD Anderson as well as outside MD Anderson, that if you get Ven-AZA and you become resistant to Ven-AZA, if you do start ivosidenib, it doesn't work as well. Okay, so there's some data. Maybe if you do Ven-AZA and you fail Ven-AZA, you might still respond to this new IDH inhibitor, olutasidenib. But I can tell you right now, like nobody has access to olutasidenib. So if I had somebody with IDH1, I gave them, for example, they came to me, they had gotten Ven-AZA and they failed, I would start them on olutasidenib, which is the newer IDH inhibitor. But in general, I feel like, but if you do, then look at the converse data, if you have IVO-AZA and you fail IVO-AZA, like say 2 years later, you relapse, there's data that suggests you can still use Ven-AZA in that setting and it'll still work. So I'd rather do IVO-AZA first. I think it's better tolerated. It's outpatient. I've had patients on it for 2, 3, 4 years. Should they ever come back to me and relapse, I can use Ven-AZA as opposed to the other way around. So I feel like that gives me an additional layer of security that for these older patients, they don't have other therapies. So what you want to do is you want to preserve as many options for them as possible so they can lead, and you want them to lead a normal life and be an outpatient for as long as possible.
Fantastic answer, ma'am. Thank you so much. Very similar kind of question from Dr. Shailesh. In patients who are NPM1 mutant AML, and patient is not available for, because we have got financial constraints for revumenib, because our patients have lots of financial problems because of the insurance and all. So 3 things he wants to compare: fit, very fit patient, young, very fit patient, NPM1 mutant AML. What would be the best? 3+7 versus FLAG-GEO versus CLAG-GEO versus EZA plus Ven. So out of these 4 combinations, what would be your best for young, fit, very fit NPM1 mutant AML?
So I think there is data that in a young, very, very fit AML patient that I would, I feel like you should definitely give an intensive regimen. So I don't think in a very, very fit young patient with NPM1 that really I would use Ven-AZA at this time. So I would either use 7+3 GO or I would use FLAG-GO. I think that the MD Anderson data has had some very encouraging data incorporating like a FLAG-GO or like a higher intensity cytarabine-based approach plus GO in favorable risk patients, and their results are like outstanding. So I think I could, and I have done this in a rare patient, 20 or 30-year-old, very, very fit, maybe we should, that could tolerate the intensive therapy. you could consider flag GO versus 7+3 GO, depending on whether they're very, very fit or not. That being said, when you look at the data from MD Anderson for the flag GO, we're really looking at very fit people. The median age of the flag GO patients, I think, is in the mid-40s, right? Which means that more patients are under the age of 40 than above. So for a 65-year-old, very fit patient, or a 60-year-old or a 55-year-old, I may be still going with the 7+3 GO backbone as opposed to a flag GO or flag GO. I think for a 20 or 30-year-old, if you want to make the case that they can tolerate it, I would do a flag GO. I would not do Ven/Aza in a very, very fit younger patient, because the goal with a young fit NPM1 patient without FLT3 would be to get them negative and cure their disease, so they never have to have transplant, and after 6 to 12 months they're done, right? I think in those patients I would follow with high dose cytarabine consolidation. I would do GO with 2 consolidations out of 4 if possible. And with that type of approach, I have cured patients. There's data suggest those patients may not need transplant. So I think you would not be wrong to do either one of those regimens with maybe a flag GO because they're very, very fit.
Thank you so much, ma'am. Another question is from Dr. Hitha B. How do you select your patients for oral azacitidine?
So oral azacitidine is not the same as IV or sub-Q azacitidine. Oral azacitidine is only 20 to 30% the drug levels of sub-Q or IV azacitidine. So people think like oral azacitidine is the same as IV or sub-Q. It's not. So oral azacitidine in my practice has a very limited role. The FDA indication suggests that if you have a fit patient and you give them they're 50, say they're 60 years old, 60, 65, they look pretty fit, and they have like NPM1 mutant disease. So you give them, 7+3, or say you give them flag GO or something, and they're in cycle 1 and they don't do very well, they don't tolerate it, they develop like bacteremia, then they have a fungal infection, they're in the intensive care unit. Finally, you get them out of the hospital 5, 6, 8 weeks, but they really almost died. And this is a patient that maybe took a long time to recover their platelets. So they were very, very sick. And so you're very hesitant about giving them a high-dose cytarabine regimen. And certainly this person's not going to be able to get through 3 or 4 cycles of a high-dose cytarabine, or even 1 or 2 cycles. So the situation where I give oral AZA is in that type of situation. I have somebody that really didn't do well with induction. Maybe I tried to give them consolidation. Their platelets went to 0. They ended up being hospitalized again. So I'm like, there's no way I'm going to be able to get this patient through 3 or 4 cycles of high-DAC consolidation. But I know for a fact that if I stop now, they're going to relapse. In that situation, I would use oral azacitidine. If somebody that could not finish intensive chemotherapy, but they don't have disease now, right? So I don't really want to give Ven/Aza to them because they have no disease, and I don't want to make them cytopenic, and how am I going to follow it? So in that type of patient, if I don't want to give them Ven/Aza, they didn't finish the intensive chemo, I might give them oral azacitidine. And so I have a few patients that are getting oral azacitidine in that particular situation. When do I stop the oral azacitidine? Well, the Quasar study sort of said to continue it indefinitely. So I'm continuing it indefinitely. I do it for at least 2 years, and I do it indefinitely. I certainly have some patients that have not relapsed with that approach. I've also had some patients where I put them on the oral azacitidine, they immediately relapsed. And when they did that, I then went to a Ven/Aza based approach, and I've abandoned the oral AZA because the oral AZA is just a tiny amount of AZA, right? So it's really not enough for treatment. It's only probably good enough for maintenance. It's only good enough in maintenance in somebody that hasn't gotten Ven/Aza prior induction, because if they got Ven/Aza induction and they went into remission, then I would continue the Ven/Aza, right? So very limited role.
Thank you, ma'am. Another question is from Dr. Shailesh. If a young fit patient who is NPM1 positive by NGS on AZA plus venetoclax remains MRD positivity by NGS for NPM1, not offering transplant, would you suggest azacitidine maintenance in such case?
So I would not use oral azaven. I mean, if you want to use an oral agent, I think that what we're using in this country is we've looked at oral decitabine. Oral decitabine is 100%, is 97% the same as IV decitabine. So if you were going to use an oral HMA upfront, I would not use oral AZA because oral AZA is only 20 or 30%. But okay, so you give oral azacitidine now. So if you give oral azacitidine, they go into maintenance. The plan would, if you give an HMA vent and they go into CR. Again, I think this is the same question as we had before, right? In the beginning, is an NPM1 patient comes in, they're young. You, for some reason, have not given them intensive chemotherapy. You've given them oral, you've given them HMA ven, you've gotten them into a remission, but they're still MRD positive or whatever. Could you now give them HIDAC consolidation? And I think that's a lot of people. When I was in India earlier this year, in Mumbai, actually in January, that was what I was hearing a lot of people were doing, is they were doing ven-aza induction because of practical reasons. Patients couldn't be hospitalized, etc. And they were hoping to then do HIDAC consolidation for these people. So I think if you're able in a young person, for some reason did not give them 7+3 or FLAG-GO up front, and you want to give them HIDAC consolidation to try to clear up their disease, I think that's perfectly reasonable. But I don't know. There is no data. There's no data that says for NPM1 mutant patients, ven-aza is okay as induction. There's no data that suggests that that's the same as induction as a 7+3 or a FLAG-GO for a young patient. So if you did that because of practical reasons, because they couldn't otherwise get therapy, then my suggestion would be, if possible, to move back to a standard HIDAC consolidation, particularly if they are MRD positive, because an oral HMA, if you gave an oral HMA, it's only 20%. If you gave oral AZA, you only gave 20 or 30% of AZA, plus you gave ven, right? So now you have an inadequate, it's not even, you didn't even give full ven AZA. You gave 30% of AZA and you gave ven. So the way that ven works is ven enhances the activity of the chemotherapy. So when you give in the relapse refractory, so in the initial studies of ven, they gave ven to relapse refractory patients, and the response rate was 19%. Okay, so ven in and of itself does not have a lot of activity in the relapse refractory setting. It doesn't work. But when you gave ven plus AZA, the response went from like 20, 29% to 67%, right? So if you remember in medical school, there was this concept like additive versus synergistic. So if you have two drugs that cause 20% response rate, and you add them together, so 20, then the response rate should be 40. If you take two drugs, they're 20, and you add them together and the response rate is 67%, then you have synergy. So the way that ven works with AZA is it enhances the activity, because AZA alone, HMA alone, is like 20 or 30%. Ven alone at max, maybe 20%, but you're getting a 67% response rate. So it must be synergistic. So similarly, when you add ven to 7+3, or you add ven to CLIA, or you add ven to FLAG, the MD Anderson's group is, when you add ven to anything, it makes it work better. The way the ven works is that cancer cells upregulate BCL2, and that prevents them from undergoing apoptosis or cell death. Your chemo is supposed to cause cell death in your cancer cells. It cannot do that in a certain number of cells, particularly leukemic stem cells, because those cells are protected by upregulating BCL2. So when you hit BCL2 and you drop the BCL2, your chemo works better. So if you only gave 1/3 of the chemo, and with the ven cannot, and it works by enhancing the chemo. So if you gave less chemo, it works less well, right? So I think if you gave an oral AZA and you gave ven and you're still MRD positive, that's good. You barely have a little bit of disease control, but you have a lot of disease. So I would either move to a HIDAC consolidation, because NPM1 mutant, to try to get rid of the disease. Okay, or if you can't do high-dose cytarabine, I would do high-dose cytarabine. I might even add GO, because you didn't do it up front. And that would have been, I would have added it up front. If you can't do that, because you're not going to give 7 and 3 GO, or you're not going to give flag GO at this time because you didn't give it up front. I would do high deck consolidation plus or minus GO if you have it for a few cycles. Try to get your patient MRD negative. Okay. If you can't do high dose consolidation, if you want to do a ven-aza, you have to give the full dose ven-aza. But I don't think that ven-aza in and of itself is for a young patient is going to be my choice, because in this patient, they have 40, 50 more years of life. I'm going to give them aggressive therapy to get rid of the disease. Does that explain things?
Thank you. Perfect, ma'am. Absolutely. Beautiful concept. Thank you so much, ma'am. Another question is from Dr. Roshni Bhagwat Pandey. 40 years old, NPM1 mutated AML, in complete remission, has got lung nodules. Patient had fungal infection, so given 45 days of liposomal amphotericin B and 1 cycle of azacitidine. Lung nodules decreased, plant fluorocytarabine with minimum dose. What would be the dose now? Because patient already has fungal infection and now into consolidation. Would you like to go for 1.5 gram per meter square versus 2 gram per meter square versus 3 gram per meter square twice daily on day 1, 3, 5? So 1.5 versus 2 versus 3 for the patient who has fungal infection during induction given azacitidine plus venetoclax and treated with liposomal amphotericin B.
Okay. And so what was their underlying mutation? It was favorable.
NPM1 mutated AML.
Okay. So, I mean, I think that if the lung nodules, so I think I would favor giving high dose cytarabine. I think you certainly could get away with 1.5, because, 3 would be better, 2 or 3. But I feel like, if you were to do high dose cytarabine for the NPM1 mutant disease, I feel like you could use a lower dose because you don't want to cause cytopenia. That being said, if the lung nodules are decreased, so like in our center, our infectious disease people feel that you need really 6 to 8 weeks to get rid of a fungal infection. So if the patient's still on a fungal treatment, then I would be a little hesitant to give a high dose cytarabine based regimen in that person, even if it's like 1.5 or 2 or 3. So I feel like if the disease is somewhat controlled, if you have a remission now, but maybe they're still MRD positive, I think it would be reasonable to give another cycle of ven-aza, because I feel like if you decrease the ven from maybe 28 days to 21 days, or even 14 days, and you don't cause so many cytopenias, that will allow you to give the finish up the liposomal amphotericin, because in order to clear the fungal infection, you're going to need neutrophils. And if you make the patient severely neutropenic, then you run the risk that if the fungal infection is not completely treated, that it will explode again. So I think you can make a case that for the next cycle, if the patient is in CR, to give ven-aza, like a shortened course of ven with aza, just not to cause severe neutropenia. Or if the patient is under control, you could even give aza alone. I don't know, but I definitely think some sort of a small dose of ven and aza for the next cycle until your liposomal amphotericin and your lung nodules are gone. And then after that, the decision should be made. Could you, if their lung nodule is gone, they're off the amphotericin, they have had a period of time where they had neutrophils to get rid of the disease, then I would switch back to a high dose cytarabine based regimen. And I think you could get away with 1.5 or 2 grams in that particular setting. But that would be my thought process. It seems to be all the questions are on NPM1 mutant AML.
Yeah. Another question is again from Dr. Shyam. What is the dose of HiDAC what you use in current practice?
So for patients who have favorable risk disease, meaning NPM1 mutant without FLT3, patients who have inversion 16, translocation 821, or BZIP, double mutations in TBBP alpha. The dose I use is 3 grams per meter squared. for 3 to 4 cycles. For patients who do not have favorable features that have intermediate risk or unfavorable risk. So for intermediate risk, I tend to use 1.5 grams per meter squared for consolidation because there's no evidence, and actually there's a paper in New England Journal Evidence suggesting that for patients who have intermediate adverse risk, just confirming again that in those patients using a 1.5 to 2 grams per meter squared in high dec is probably better because those cells are not exquisitely sensitive to high dose cytarabine. So giving more in those patients is probably more detrimental than beneficial. So, and then in patients who have adverse disease, definitely would not use the 3 grams. I would give maybe 1, if at most, therapy, or I would think about, and I'm thinking about sending them to transplant. So I try not to do a lot of consolidation in adverse risk. If anything in adverse risk, I only do 2 cycles. My goal with adverse risk is really to get them to transplant.
Thank you, ma'am. Another question is from Dr. Christopher Chin. A patient with AML with CNS involvement, with or without specific mutations, what would be your approach?
So patients at diagnosis that I know have CNS relapse, if I knew they had CNS relapse at diagnosis or disease at diagnosis, I would favor an intensive chemotherapy regimen like a flag or something that has at least 1.5 grams per meter squared of cytarabine to penetrate the CNS. If I give them standard therapy and then they develop CNS disease, then I typically start with intrathecal cytarabine. And I do intrathecal cytarabine. Our standard practice is to give 2 intrathecal chemotherapies with cytarabine, like 70 grams to 70 milligrams with steroids twice a week until they clear. And then we do once a week for 4 weeks. And then we move to once a month for 12 months. If they don't clear after several cycles of just cytarabine alone, then I will add the methotrexate and I will do cytarabine, methotrexate, and steroids, which is what we call triple therapy for patients in that particular setting. I tend not to give intrathecal methotrexate. I give intrathecal methotrexate as my first choice for ALL, but I find in AML, I only add the methotrexate as a second drug if the cytarabine alone is not working. And I usually only give the cytarabine if they're not getting like a high dose cytarabine containing systemic chemotherapy. So it's really important to control the CNS relapse before transplant. So if somebody has CNS relapse, I do that. I do the twice a week until it clears, then once a week for 4, and then once a month. Once we get to the once a month, I think that the disease is under well enough control that they could go for allogeneic stem cell transplantation, but we maintain the once a month intrathecal therapy throughout transplant and after transplant to prevent CNS relapse. Because as you know, the transplant will just replace the disease in the bone marrow and the blood. But if you have persistent CNS disease, you have to control it before transplant and after transplant. Otherwise, it can be a source of isolated relapse. And I've had people, and then if they have CNS disease, prior to transplant, even on that schedule, for younger patients, we're really advocating a myeloablative transplant and total body radiation. Because once you have extramedullary disease, you're likely to have it somewhere else, right? So you really need at the time of transplantation to ideally incorporate like a TBI approach into your conditioning for those patients that have known extramedullary relapse.
Thank you, ma'am. And another question is, what would be your approach for isolated myeloid sarcoma without marrow involvement?
So isolated myeloid sarcoma is always a systemic disease. So people think, oh, it's myeloid sarcoma, I could radiate it, it'll be fine. It's always systemic disease. So even if you do the marrow and you don't see evidence of any, that's great. It's good actually if you don't see clear evidence, but the disease is always systemic. So if you want to treat a myeloid sarcoma, you have to give systemic chemotherapy. And our goal has been really to give a 7+3 based approach if at all possible, just because we think it's more intense and more cytotoxic and has a better ability to clear other extramedullary sites. So for patients that have a myeloid sarcoma, we always do an LP and we always do a marrow. So if the LP is negative, we always put something in there, because once you've escaped the bone marrow, you're out there, you can do anything you want in that patient right now. So it's really important to work, though, not to just say, oh, I have a myeloid sarcoma, I'm going to go ahead and treat. So we do a couple things. So we do a PET scan, a PET CAT scan in everybody to look for other sites of extramedullary disease. We do a LP with a 1 dose of intrathecal cytarabine just to put it in there, just to check to see whether there's, even if there's nothing there, you want to put something in there. And we always do a marrow. And if the marrow, even if the marrow is negative, we start systemic chemotherapy, ideally with a cytotoxic regimen like a 7+3 or a CLAG, because we know that it is going to be everywhere. And we then again would prophylax, maybe do monthly ITs in that person and get them to transplant.
And can you, madam, is it possible to go for molecular stratification in all such cases with myeloid sarcomas and all?
Yeah, so it's really important in myeloid sarcoma, before you start therapy, you have to do diagnostic testing on the myeloid sarcoma cells. So we have had a patient that came in with just an isolated abnormality in their spinal cord and and we biopsied this and we sent it for studies, and it turned out it was APL. So you have to, so then we treated the patient with arsenic and the patient was completely cured. But so it's really important in the myeloid sarcoma to do the testing to check for, by FISH, for APL, inversion 16, 821, KMT2A. You know, you need to do all of, as much as possible, do the diagnostic testing in the extramedullary disease site. Rarely, we've also had patients who presented with extramedullary or myeloid sarcoma that had a BPDCN, right? Which can be treated with a CD123 agent. So you need to look to rule out BPDCN. You should probably rule out APL just in case, and you need to make sure that it's lymphoid versus myeloid. And if it's myeloid, if you can do like fluorescent in situ, because you don't have a lot of tissue, right? You can't culture it for conventional cytogenetics. So you have to potentially do specific cytogenetic probes, because there might be a targeted therapy that could work in those patients. You know, we also try to get some material from the slides. You can do like this tumor capture where you can take the pathology slide and take the cells off the slide and degrade it, and get nucleic acid and do mutation testing, because if you have a FLT3 abnormality, you could add a FLT3 inhibitor. So it's really important to do all that, because once the problem is that you want to do that if possible before you, unless it's like a spinal cord compression or something like that, it's really important to get as many biopsies and to characterize the disease as possible before you start therapy, okay? Because we've certainly had colleagues that thought this myeloid sarcoma was a lymphoma, or they thought it was a sarcoma. They started therapy and then it didn't, it came back. I had one unfortunate case where the patient presented with a myeloid sarcoma, was sent to like lymphoma. They thought it was a lymphoma, or sarcoma, treated it as a sarcoma, came back a few months later. They were presenting it at the sarcoma tumor board, and somebody said, hey, there's a FLT3 mutation or a DMNT3A mutation. And the pathologist said, you know, this is not a sarcoma mutation. This looks like a hematologic mutation. So then sent it to us, and it turned out the patient did not have a sarcoma. They had a myeloid sarcoma, and they had gotten like 6 months or a year of sarcoma-based therapy. And when it recurred, you know, that's when they discovered it. And so we tried to treat the patient, but she had been so heavily pretreated for her sarcoma diagnosis, she didn't tolerate now the leukemia treatment. So she actually progressed and passed. But I think it's important. I think sometimes people feel like they must rush in there and, you know, start radiation or start high dose cyclophosphamide, and then you destroy the tissue and then you can't make the diagnosis. So it's important to do that.
Thank you, ma'am. Another question is from Dr. Lee Kit Tet. She has a 20 years old male with AML with inversion 16, and NGS shows positivity for NRAS mutation. He achieved MRD negative for CBF MYH11 mutation by PCR, after induction as well as consolidation, should we still go for transplant in such case or only reserve it upon relapse?
So if they have a favorable risk, I think I would go forward with the high-dose cytarabine diagnosis and treatment. And then if they're MRD negative, then I think that it would be, I don't think you necessarily need to go for transplant in that setting. If they're MRD positive, then I think it would be helpful. Then I think at that point we would pursue transplant and we would try to get them back into remission, maybe with the Ven-Aza-based approach if they've had a cytarabine-based approach up front, and then send them to transplant.
Thank you, ma'am. Another question is from Dr. Roshni Bhagwat Pandey. What should be the approach for a 25 years old AML with translocation 611?
So a young patient, I would probably give them a 7+, get an intensive chemotherapy regimen, either a 7+3, or if you want to use, if they're very young, a FLAG-GO or CLAG-GO or CLIA-GO, something. I would definitely give them a intensive induction, and then I would pursue an allogeneic stem cell transplantation in CR1. In our center, we have the availability now of some upfront menin inhibitor trials, so we would potentially, given the KMT2A, would add a menin inhibitor, potentially ideally to intensive chemotherapy at the time of induction. And we would potentially continue the menin inhibitor during consolidation to try to optimize the disease control before sending them to a transplant. But our goal for those individuals would be a transplant.
Thank you, ma'am. Another question is Dr. Hitha B. Patients with AML with complex cytogenetics, FLT3 positive, in complete remission 2, CR2, after 7+3 as well as MAS, that is MEC regimen, cannot afford FLT3 inhibitors, not willing for transplant. How to go for maintenance in such cases?
I do think that in those patients, ideally, we would use a FLT3 inhibitor. I think you are limited by what you can do for that person. So I think that you could give low-dose cytarabine, LDAC. You can certainly try oral azacitidine. I think something is better than nothing, because I think that person obviously is high risk of relapse. If the targeted therapy is not an option, then I think any therapy would be better. I think oral azacitidine or low-dose cytarabine maintenance would be good. I don't know that there's any benefit to venetoclax regimen, because I think venetoclax, as we mentioned, really enhances the activity of the other. So I don't think venetoclax alone. Would you add venetoclax to oral AZA or anything? I don't know that there's any data for that. So I think I would try some sort of low-dose chemotherapy maintenance for now. And then I think trying to get them on a FLT3 inhibitor would be the ideal if able to obtain that. And sometimes you can write the drug companies and explain the situation and see whether they would provide some drug on a compassionate basis, because it's not actually that expensive to make these drugs. They just charge an exorbitant price for it because of the profit margin.
Thank you, ma'am. Another question is from Dr. Shyam, and this is the second last question. AML with inversion 16, how long do you go on monitoring? Number one. And how long can NGS remain positive?
So my inversion 16s, I follow them for the rest of their lives, even if it's once a year. In terms of MRD testing, the data suggests that they should be negative if they got intensive chemotherapy after 2 lines of intensive therapy. So like in Europe, they usually give 2 inductions, right? In the US, we give 1 induction, 1 consolidation. So they really should be negative, ideally after 1, if not 2 regimens. So if they're still positive after 2 cycles of intensive chemotherapy, then I think that's a problem. And then that would be suggestive that they're not responding to therapy. And in those patients, I would change therapy, and I would potentially, if they're young, look at an allogeneic stem cell transplantation. If they are negative after 1 or 2 cycles, I think it's possible to continue with the standard upfront therapy and continue to monitor. We check MRD at our center every 3 months. As I said, I mentioned earlier, we check it in the marrow. If it's negative in the marrow, we do peripheral blood. We typically follow patients in the peripheral blood every 3 months for the first 2 years after finishing therapy. We then go to every 6 months for the next 2 or 3 years, and then about by 5 years, if there's no evidence of disease. I usually do the MRD testing intensively for the first 2 years after therapy, and then I see them maybe once or twice a year, and then around 4 to 5 years, I'm seeing them once a year, and then I do once a year follow up for the rest of their lives. And that's not necessarily because I feel like the disease will come back, after that many years, but because there could be an instance of secondary MDS or secondary leukemias or secondary cancers. So that's the other reason I follow them for the rest of their lives.
Thank you, ma'am. Another question is from Dr. Shyam once again. He has a 30 years AML, post-transplant, 3 years now presents with CNS myeloid sarcoma, 100% donor chimerism. How do you approach?
Okay, so for CNS relapse, so again, I would do the intrathecal twice a week until they clear, and then I would do weekly for 4, and then I would do monthly. But if they're 100% donor chimerism, the other thing you can do, which I've tried to do, haven't said, but there is data to suggest that donor cells might be helpful in this setting. I mean, there is some data with CAR T for patients with ALL with CNS relapse that CAR T therapy can actually infiltrate the CNS. That's why you get like those, like when you have patients blinatumomab or you give them CAR T, they get those CNS manifestations. And I think that is reflected, like that the CAR T cells can go in there and can have some effects. So I would think if you have the ability to do donor lymphocytes, that would be something that you could do. However, if they're 100% donor chimerism, so if you lose a little bit of the chimerism and you have CNS relapse, you could make the case whether a DLI would be something that your transplant, at our center, we have a separate transplant center. So I think I would potentially I would clear the CNS with CNS directed therapy. And I would think about if, you were concerned about potentially donor lymphocytes. However, if you're 100% chimerism, it may or may not be possible to further enhance that. But the question is, and then you can ask, I don't know whether there's evidence for donor lymphocytes to go into the CNS. I know there's evidence for CAR T cells to go into the CNS, but I think right now the standard would be intrathecal. If they did not get TBI at the time that they had their transplant, the question would be whether, depending on how much CNS disease you have involvement, like if you have parenchymal lesions, then you might want to consider maybe radiation as well as intrathecals, but not simultaneously, but sequentially. If there's large burden like in the CNS and the parenchyma, and you might want to consider consolidative radiation to try to minimize that. Would you start systemic therapy for CNS relapse? I think that's a plus minus. Some people might start chemotherapy if there was systemic involvement. I think for just isolated CNS, if you're not having marrow disease and you're 100% donor, I think that's a plus minus. I think it depends on the situation, whether you would really restart or not.
Would you go for a second transplant now, in such case?
I think I would if you had the option, because I think that, I don't know. I mean, I think it depends. I mean, I think if you're able to control the CNS disease and it's just an isolated CNS, then you might not need to, but sometimes CNS relapse is a harbinger of systemic relapse. If there's any indication you're losing your donor chimerism or there's any systemic disease, then I think it's a low, and depending, like if the person is like 70 years old, maybe not. If they're 27 years old, maybe I would think about a second transplant somewhere and explore that. Because I think in many cases, CNS disease is an early harbinger of systemic relapse. And I think you need to be thinking about that depending on your patient and whether they would be a candidate to get additional therapy. But if you give them additional systemic, if they need systemic therapy, or if you decide on systemic therapy, you're going to eradicate the donor cells, right? So then you need to really seriously think about either donor lymphocytes or a second transplant if you're going to give them systemic therapy that is going to impair and lead to the original patient coming back, right? But that's a difficult situation.
Thank you, ma'am. The last question is from Dr. Krishnanathan Kannan. How do you treat blastoid plasmacytoid dendritic cell neoplasm, BPDCN?
So we have in this country the availability of a couple of targeted therapies. We have this tagrasfopus, which is a CD123 antibody conjugated to a DNA, not a DNA damaging, but a diphtheria toxin. So it's basically a bacterial toxin, similarly what you get when you have a gram-negative bacteremia, where you get like chills, rigors, capillary leak because of the bacterial toxin, conjugated to a CD123 antibody, because BPDCN, which affects larger, older patients, men more than women, with BPDCN, and with the skin lesions as well as marrow disease, tends to be very, very high expressing, like probably the highest expressing CD123. So my standard would be in a patient who's fit, that is, does not have malnutrition, would be to do a CD123 antibody drug conjugate that is given every 3 weeks, initially in the hospital, subsequently outpatient. And then if the patient achieves a response with that, which occurs in like 70 or 80% of patients, would be to pursue an allogeneic stem cell transplantation, even a haplo we've done at the time of remission. If you don't have the antibody drug conjugate, then your options is chemotherapy. And Ben-Aza actually works very well in patients to get a response, particularly in older, unfit patients, which represent the majority of people that have that. Unfortunately, Ben-Aza, as well as tagrasfopus, have a very short duration of response. The patients probably relapse within that therapy within a matter of months in the absence of allogeneic stem cell transplantation. For younger, fitter individuals, our standard has been like hyper-CVAD, so we treat them like as an aggressive ALL. The data has suggested that intensive, like lymphoid, either ALL or lymphoma-based therapies work best in getting in a younger, fitter patient and getting them into remission. There's studies looking at adding a CD123 to a hyper-CVAD regimen or a Ben-Aza regimen. Again, though, this is a disease that is very aggressive, so allogeneic stem cell transplantation would be needed. It's also a disease, interestingly enough, that has a lot of CNS penetration. So we found at the time of relapse that a lot of people have had like CNS disease. So now, as part of our diagnostic workup, we always do an LP for patients with BPDCN and make sure that we monitor that area and put prophylaxis in there.
Thank you, ma'am. And last question just came up from Dr. E. Montent. What would be your conditioning chemotherapy as well as GVHD prophylaxis for haploidentical stem cell transplant or for allogeneic stem cell transplant in your current practice?
So I don't do allogeneic stem cell transplant because that's a separate group. However, in our center, we are increasingly using for GVHD prophylaxis post-transplant cyclophosphamide for all of our patients, and that has dramatically reduced the rates of acute GVHD and improved survival. I think I saw a recent statistic from our center that our 6-month overall survival since we've implemented post-transplant Psi is in the range of 90 to 100%, because patients are surviving the transplant and are not dying of acute GVHD in the first 3 to 6 months after an allogeneic transplant. It's also allowed us to expand our donor pool, so we've been able to use more donors that are potentially a little bit mismatched because of the post-transplant Psi. That being said, the use of GVHD prophylaxis with post-transplant Psi is associated with a significant increase in relapse, because by affecting the T cells that are responsible for GVHD, you're also impairing the T cells which are responsible for graft versus leukemia. So we have noted, and it has been reported in the literature, an increased relapse rate from particularly AML and myeloid neoplasm patients. Probably 20 or 30% of those patients are coming back to us and have evidence of recurrent disease. So that has strengthened the argument that we need to be thinking about using some sort of routine maintenance post-transplant to prevent relapse. So we have been very aggressive about using FLT3 inhibitors, IDH inhibitors. We've been using menin inhibitors on clinical trials. We've been investigating, and I don't know that we've had a lot of success. There is data looking at, we have not been using ven-aza post-transplant, but we have been using decitabine with growth factor, which has been published to use a low-dose decitabine every 6 or 8 weeks with a little growth factor post-maintenance. We've been trying that, and we're waiting the results of the Amadeus trial from the UK, which is looking at the results of using oral azacitidine post-transplant, but that is a challenge that we've been struggling with recently.
Thank you, ma'am. And last question, by Lemon Tent, for the patient who is a favorable risk AML, doing very well with AZA plus ven induction, MRD is negative, doesn't want to take HiDAC. Should we go on continuing HiDAC, AZA ven in such cases, and we can skip HiDAC by any chance?
You can continue if it's a young, I do not recommend that because I don't, although I have a older patient that has done very well, favorable risk that has been AZA for many years and is now and still there a few years later. It's a continuous therapy. You can never stop AZA ven. Never, ever, 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 ever. And so I would argue to this patient that if they're younger and fit, that if you have the possibility to have your disease be eliminated by HiDAC consolidation, that the trade-off is 6 to 12 months of HiDAC consolidation, making your MRD negative, and then you maybe could stop, as opposed to endless ven-aza. So, and I would think that, I would only recommend continuous ven-aza for patients that are older and unfit for whom they really can't tolerate it. Otherwise, I think a HiDAC potential regimen with GO ideally would be my choice.
Perfect.
Okay.
Well, thank you so much, ma'am. Thanks a lot for answering all our questions this last 2 hours.
No problem at all.
Doing you a lot. Thank you so much. Fantastic lecture. Wonderful lecture. What a good learning from you, ma'am. Wonderful discussion. Learned a lot.
Good luck, everybody. Best of evenings and weekends to you. Thank you.
Thank you. And I now request Mr. Somnath Banerjee to go for final vote of thanks.
Yeah. Thank you, Dr. Amit, sir. I would really like to thank my sincere gratitude to Dr. Eunice Wang, ma'am, for such a descriptive discussion on AML. And it gives us a lot of insights and we learned a lot. And we have Raksha Bandhan. I wish everyone for happy Raksha Bandhan. And thank you, Dr. Eunice, ma'am. Good morning. It was really a wonderful session. With that, I would like to greet everyone a happy weekend. Thank you, sir. Thank you very much.
Thanks a lot. Thank you, ma'am, once again. Thank you, everyone.